Good morning, everyone. I'm going to discuss case number 8, slide for diagnosis. This is the microphotograph in which an H&E stained section studied shows glomeruli and the tubules with degeneration and frank necrosis of the individual or of segmental epithelial cells. There are tubules with flattened, regenerating type of epithelial cells with degenerated epithelial cells in the tubular lumen. Here we can see degeneration and the collection of the cells with frank necrosis. So, the diagnosis is acute tubular necrosis. Acute tubular necrosis. It is the most common cause of acute renal failure. It is a tubulointerstitial disease which causes reversible destruction of the tubular epithelial cells with acute suppression of renal function. Etiology. Tubules are sensitive to injury due to vast electrically charged surface for reabsorption, active transport for ions and organic acids, and the ability to concentrate. There are two types: ischemic, nephrotoxic. Ischemic injury, also called acute vasomotor nephropathy, due to inadequate renal blood flow, often from marked hypotension and shock, which is seen in acute pancreatitis and severe trauma. Ischemia causes vasoconstriction, which leads to reduced glomerular filtration rate and oliguria. Second type is nephrotoxic. It is caused due to carbon tetrachloride, cisplatin, ethyl glycol, gentamicin, hemoglobin, that is transfusion reaction, and malaria, lead, light chains like myeloma, mercury, methotrexate, myoglobin from crush injuries and myositis, muscle toxins, radiographic contrast agents. Greatest injury is to proximal convoluted tubules. Clinical features. It is divided into three phases: initiating phase, maintenance phase, and recovery phase. Initiating phase. It is from 0 to 36 hours, decreased urine output, elevated BUN and creatinine due to decreased blood flow. In the maintenance phase, 40 to 400 ml of urine per day is produced and the salt or water overload takes place, along with hyperkalemia, acidosis, and uremia, which may need dialysis. Recovery phase. Increased urine volume up to 3 liters per day due to tubular damage, inability to concentrate the urine, and hypokalemia occurs. These patients are vulnerable to infections. Microscopic findings. In ischemic acute tubular necrosis, there are two phases: early phase and the later phase. In early phase, it varies from cell swelling to focal tubular epithelial necrosis and apoptosis with desquamation of cells into lumen. Dilated proximal tubules with thinning or loss of PAS positive brush borders are seen, along with hyaline, granular, and pigmented cast. Particularly in the distal and the collecting ducts, eosinophilic hyaline cast of TAM horsefall protein, that is urinary glycoprotein, normally secreted by the cells, and white blood cells in dilated vasa recta, along with interstitial edema, are seen. In the later phase of the disease, the epithelial regeneration is seen, which is characterized by flattened epithelium, dilated tubular lumina, large nuclei with prominent nucleoli, and mitotic activity. So, the key diagnostic features for telling it to be an acute tubular necrosis are widespread sloughing of the tubular epithelial cells, loss of brush borders, which is best seen on periodic acid skiff stain, and flattened simplified tubular epithelium. In this photomicrograph, we can see degenerated and frank necrosis of individual or segments of the epithelial cells. There are tubules with flattened, regenerating type epithelial cells with degenerated epithelial cells in the tubular lumen. This is a photomicrograph which is of a special stain, that is periodic acid skiff. Here we can see toxic acute tubular injury with vacuolated intact epithelial cells and sloughed necrotic epithelial cells in some tubular lumina. Other tubules have flattened epithelial cells and some show frank necrosis. Nephrotoxic type of acute tubular necrosis. Here there is extensive necrosis of the tubular cells along the proximal tubules. Different types of nephrotoxic substances show different features. For example, carbon tetrachloride, we can see neutral lipid accumulation or fatty change in the injured cells followed by necrosis. Ethylene glycol, it shows ballooning and hydrophic changes of the proximal tubules, calcium oxalate crystals in the tubular lumina. Hemoglobin or myoglobin, there are numerous deeply pigmented red-brown casts in the distal and collecting ducts. Indinavir. In this type of nephrotoxicity, intraluminal clear crystals with mononuclear reactions are seen. Lead. Dark intranuclear inclusions and necrosis is seen. In mercury poisoning or mercury toxicity, you can see large acidophilic inclusions. Tenofovir. It shows distinctive proximal tubular eosinophilic inclusions representing giant mitochondria. In vancomycin use, acute interstitial nephritis is seen with lymphocytic and eosinophilic infiltrate and acute tubular necrosis. On immunofluorescence microscopy, no specific staining is seen. Electron microscopic findings. There is sloughing of tubular epithelial cells into the lumen. The injured tubular cells show loss of brush borders, apical blebs, and swollen mitochondria. Tubular cells may exhibit vacuolization and simplification of interdigitating basolateral enfoldings. In aminoglycoside toxicity, there are lysosomal myeloid bodies. Amiodarone toxicity shows atypical mitochondria, and lead toxicity demonstrate intranuclear lead inclusions. Differential diagnosis. Acute tubulointerstitial nephritis, light chain cast nephropathy, light chain tubulopathy. Acute tubulointerstitial nephritis, it shows tubular injury along with marked interstitial inflammatory component with tubulitis. Light chain cast nephropathy shows tubular injury along with pale blue amorphous masses that fill and distend the lumen surrounded by giant cells and histiocytes which are containing rhomboid or needle-shaped crystals. Those are the crystals of light chain casts. Light chain tubulopathy associated with significant tubular injury and intracytoplasmic crystals of various shapes within tubular epithelial cells which are PAS and trichrome positive. In all these three conditions, immunofluorescence shows a particular type of staining which is absent in acute tubular necrosis, which helps it to differentiate from other types of tubulointerstitial diseases. Thank you.